Welcome to AETCM, the Emergency Medicine Channel. Myself, Dr. AVIN Chajijon. As part of our EM Rapid 2024, I will be presenting the topic MYASTHENIA crisis. Come to the introduction. So, myasthenia crisis is basically a life-threatening exacerbation of myasthenia gravis, which is defined by worsening of myasthenic weakness, which ultimately requires invasive or non-invasive ventilation. The respiratory failure is due to weakness of respiratory muscles basically, and also the bulbar muscle weakness, which can lead to the upper airway obstruction, and dysphagia with aspiration, which further also requires invasive ventilation. So, these two causes are the main reasons why the patient will end up with intubation and ventilation. So, the respiratory muscle weakness as well as the bulbar muscle weakness. And coming to the impending myasthenic crisis definition, which is a rapid clinical worsening of myasthenia gravis that could lead to crisis in the short term, around days to weeks. The patient might end up in intubation and ventilation. And the most myasthenic crises occur in the first few years after diagnosis of myasthenia gravis, that is when the disease is in its active phase. And coming to the pathophysiology, we have basically two receptors at which the antibody acts. So, basically it is the acetylcholine receptor antibodies, and it causes muscle weakness, which is initially it affects the intercostal muscles and the accessory muscles, then only the diaphragm gets involved. And also the mean acetylcholine receptor antibody concentrations are higher in patients with myasthenic crisis when compared to patients with mild disease. And also the other antibody which we have to talk about is the muscle specific kinase antibodies, and these basically cause bulbar and respiratory muscles weaknesses. Basically they are preferentially affected. Okay, and also the MuSK antibody positive MG also tends to have a poor prognosis, in which it can require longer need for intubation as well as ICU and hospital stay. Coming to the stages, we have basically 4 stages. In this, the initial stage is when there is the respiratory weakness which causes further decrease in the lung volume, and also the compensation stage, which is basically a rapid and shallow breathing trying to compensate for that weakness. And in the ABG we will be able to find out a respiratory alkalosis picture because of the tachypnea response. Worsening of the further worsening will occur, in which the weakness worsens and the PCO2 starts to build up. Now a patient is no longer able to expire out the PCO2, and there will be respiratory collapse. And also the chronic stage involves the chronic bicarb elevation. And coming to the basic risk factors for myasthenia crisis, if the patient has any previous episodes of myasthenic crisis, they are at higher chances of ending up in crisis. And also if the diagnosis time, if the disease is of greater severity at the time of diagnosis, or severe myasthenia gravis can also lead to myasthenic crisis, then oropharyngeal weakness, and also the MuSK antibody positivity as we discussed earlier, and also the thymoma. Thymoma component is also important, as it can cause myasthenic crisis. And coming to the common triggers, we basically have the most common is the infection. Any infection, be it bronchitis, pneumonia, sepsis, can exacerbate myasthenia gravis, and also other causes like aspiration pneumonitis, reduction of immunotherapy. If the patient is on immunotherapy and we are trying to taper off immunotherapy, or a patient is not taking up the medications, then also it can lead to. And also surgery or trauma, any high stressful situation such as surgery or trauma can also precipitate. Then also it can be seen in pregnancy or postpartum. And other medications which causes which precipitates crisis are antibiotics. They commonly use antibiotics such as aminoglycosides, macrolides, quinolones, and also the intravenous magnesium, which mainly we use for the eclampsia in pregnancy. So that also is a precipitant. And the other drugs are dipenicillamine, botulinum toxin, then also the immune checkpoint inhibitors such as the monoclonal antibodies such as the pembrolizumab, nivolumab, etc. And also vaccination and also emotional distress can also lead to crisis. And next one is the clinical presentation. We have initially the presenting symptoms would be a generalized weakness or a bulbar weakness, and occasionally it can present as a respiratory insufficiency initially itself, which is out of proportion to the limb or the bulbar weakness, and sometimes it can be the only manifestation as well. And also this generalized weakness can mask the usual signs of respiratory distress, such as the accessory muscle use. So that is actually a disadvantage, and we won't be able to recognize if the patient is in respiratory distress because of that generalized weakness, and they won't be able to use their accessory muscles to compensate. And in one study also, this the myasthenic crisis, 76% of the myasthenic crisis were preceded by mainly increasing generalized weakness, whereas 19% showed a deteriorating bulbar weakness and 5% showed worsening of the respiratory function. And coming to the examination, the signs of myasthenic crisis should be monitored in all myasthenic patients in general, and even with patients who does not have symptoms of dyspnea or breathlessness. And they can also present with symptoms such as ophthalmoparasitosis, facial weakness. All the bulbar palsy signs can be present, and they in facial weakness they won't be able to hold the air within the cheeks, and also there will be a myasthenic snarl, it's called, while smiling. And also the jaw closure is also incomplete after chewing, and also the other bulbar weaknesses can also lead to hypernasal dysarthria, then the hoarse speech, dysphagia with nasal regurgitation, and difficulty clearing secretions. And also the weak cough, it reflects significant expiratory muscle, not an inspiratory muscle, expiratory muscle weakness, and that is manifested by the weak cough. And coming next, we have the tongue weakness, which is assessed by asking the patient to protrude the tongue against the cheek and pressing against it to check for the power of the tongue. And further we have to evaluate for the neck flexion weakness, as it helps to correlate with the diaphragmatic strength rather than the limb weakness itself. So the neck flexion also has to be tested, and also the most reliable testing is the paradoxical breathing. And also we can also see hypophonia, inability to complete full sentences, increased respiratory rate with shallow breaths, and the use of accessory muscles of respiration can also be seen. And the next one which we can easily use is the single breath count. So we'll ask the patient to take a normal breath in and then to count out aloud the numbers, approximately 2 counts per second, and we'll assess and compare every hour if he is deteriorating or the numbers are decreasing or not. At least 20 or more is adequate, and if there is any progressive, the basic thing we have to see is the progressive worsening of the count, and also rarely we can see stridor and vocal cord palsy. So this is the myasthenic snarl due to the facial weakness, and also these are the basic signs which we can see in an impending myasthenic crisis. So there will be, as we said, muscle weakness or generalized weakness, then there can be eyelid droopiness or ptosis can be present, the diplopia can be present, impaired speech can be present, difficulty swallowing, dysphagia can be present, and also the facial expressions can also be altered, and they can also have trouble breathing. So these bulbar weakness, generalized weakness, muscle weakness, the respiratory muscle weakness, all of these together we will have to watch out. And coming to the diagnostic evaluation, the myasthenic crisis is basically a clinical diagnosis as characterized by the increasing respiratory muscle or the bulbar muscle weakness, as we mentioned earlier, requiring intubation and mechanical ventilation. In 20% of cases, the myasthenic crisis is the first manifestation of myasthenia gravis, and it actually can present without prior diagnosis of myasthenia gravis as in a respiratory failure presentation, and we won't be able to make out that it is a myasthenia crisis. So, one of the differentials we will have to think about is when the patient presents with such a neuromuscular respiratory failure is myasthenia crisis. And also the diagnosis, if we suspect, we have to confirm it with, we can use the adrephonium test. Adrephonium test can be used in which the patient drastically improves his symptoms, he gets symptomatically better. And also we can use the electromyography, and in this basically what we do is we do the repetitive nerve stimulation, okay. And when we do the repetitive nerve stimulation and we record the signals by electromyography, we will get progressive decrease from the postsynaptic NMJ junction, so that dysfunction will be able to record. And also we can do the antibody testing, as in the serology testing can be done. And also coming next, we can do a bedside spirometry. It is used mainly to measure the vital capacity, the negative inspiratory force and the maximal expiratory pressure. And the vital capacity or the negative inspiratory force, it is also called as the maximal inspiratory pressure, just the opposite of the expiratory pressure, MIP, maximal inspiratory pressure. That is also called as the inspiratory force, negative inspiratory force. And these vital capacity and the MIP, that basically reflects the strength of the inspiratory muscle. That is what we have to know, the inspiratory muscle as well as the diaphragm, whereas the MEP is suggestive of the opposite, the expiratory muscle's strength. And we mainly measure the MIP and MEP. Mainly it represents more sensitive indices for the respiratory muscle function compared to the vital capacity. So, these two are the most important and vital measurements. And also any decline in MEP by 30% indicates a high risk of needing non-invasive or invasive respiratory support. And so, we can also it's useful in detecting patients that will require intubation progressively. And so, elective intubation can be done instead of a emergent intubation. And also vital capacity, if it is more than 20 milliliter per kg, or if the expiratory pressure is more than 40 centimeter of water, or the maximal inspiratory pressure is more than 40 centimeter, meaning it should be more on the negative side. This is the negative inspiratory force. So, that is why it is in the positive value, it is more than 40 centimeter H2O. That is, we can say, in other words, we can say MIC becomes the maximum inspiratory pressure, MIP. MIP becomes more negative than 40, than minus 40. So, in another term we can say like this, MIP becomes more negative than minus 40, then we can say the patient is at low risk. And another useful measure of diaphragmatic weakness is a fall in the vital capacity in the supine position when compared to a seated vital capacity. And coming to the major side effect of the excessive anticholinesterase medications, we have weakness. This is one of the major side effects we will have due to the excessive intake of the treatment for the myasthenia, and it is difficult to distinguish from the myasthenic crisis. So, rarely it is seen if the dosage of pyridostigmine is less than 120 mg every 3 hours, the patient is very less likely to end up in cholinergic crisis. So, only if the doses are more than this, then we have to suspect for cholinergic crisis. And we can one test which we can use to differentiate between cholinergic crisis or myasthenic crisis, that is more important. And for that we use the agent adrephonium again, the diagnostic test which we said earlier, that is used here as well to differentiate between the crisis as well, if it is either cholinergic or myasthenic. It is actually better in terms of safety profile as well, because it has a rapid onset with short duration of action, 5 to 10 minutes maximum is the duration of action, and it can be used in small dose of 1 mg initially to identify the crisis. So, if the patient has resolution of the weakness, then we can diagnose it as myasthenic crisis. Then we can further treat them with neostigmine 0.5 to 2 mg sub-Q, or we can give peroral dose of 15 mg. And also we can also increase the dose of hydrophonium as well for the same purpose. Then other one, if the patient develops otherwise, the opposite, the muscle fasciculations, the respiratory depression or the respiratory muscle weakness worsens or the cholinergic symptoms come up, then in all those cases, then we will have to suspect cholinergic crisis and we will have to not give any further hydrophonium, and we will have to arrange for atropine and give 1 mg of atropine, and it will reverse only the muscarinic effects, and we will support the airway of the patient. It will not reverse the nicotinic effects. So, we will have to make a crash cart ready while administering the hydrophonium as well, and the patient might end up in intubation, and also we will have to manage the secretions and the bronchospasm. So, that is the side effect of that specific test. And the differential diagnosis, what all we have to consider. So, most of the time the patient presents, as I said earlier, in the myasthenic crisis without a prior diagnosis of myasthenia gravis. So, we will have a confusion between whether it can be a crisis or not, because we have multiple differential diagnoses which can have a neuromuscular sort of respiratory failure. So, we have to suspect other causes such as Guillain-Barré syndrome, botulism, Lambert-Eaton myasthenic syndrome, motor neuron disease such as the amyotrophic lateral sclerosis, the autoimmune or inflammatory myopathies, the chronic inflammatory demyelinating polyneuropathy, tic paralysis, the severe rhabdomyolysis and brainstem stroke. So, these are the basic differential diagnoses we will have to see and have to rule out when a patient presents with a respiratory failure. And also coming to the management, we will have to admit the patient to ICU and we will have to measure the vital capacity every 2 hours to watch for the respiratory status deterioration. And we should also consider elective intubation if the patient has any of the following conditions, such as a decline in serial measures of VC below 15 to 20 ml per kg. As we discussed earlier, the low risk criteria, just the opposite to that, if the patient presents with, then we will have to electively intubate the patient. So, the vital capacity below 15 to 20 ml per kg ideal body weight, and the MIP pressures, as I said earlier, it is less negative than minus 25 to minus 30. So, it becomes less and less negative, goes towards the 0 mark, then we will have to intubate. Then coming to the respiratory distress signs such as tachypnea, axillary muscle use, and all that signs, or if the patient is not able to protect his airway due to the secretions, and also if there is any progressive worsening of the respiratory acidosis, and if the patient has, as we said now, the difficulty handling oral secretions or a weak cough or a severe bulbar dysfunction which can lead to the upper airway obstruction, or if the chest X-ray shows atelectasis and aspiration, then also we will have to electively intubate. And coming to we will have to stop the anticholinesterase medications temporarily in intubated patients who has to avoid excessive airway secretions, that is important. And then we will have to restart it once the patient is, when we are planning to wean the patient. And also we should also treat any precipitating factors, mainly infections with antibiotics, we will have to treat it. And the next one, we have to begin the rapid therapy. So, basically we have a chronic therapy, maintenance therapy, as well as a rapid therapy to correct the myasthenic crisis. So, first we will have to start with either plasma exchange or both IVIG and plasma exchange. We will have to start with these therapies, and we will have to also simultaneously start with the chronic therapy, which is the immunomodulating therapy with the high dose glucocorticoids, which is prednisolone around the dose of 60 to 80 mg per day. And also we will have to consider azathioprine, mycophenolate, other steroid sparing agents, so as to reduce the dose of glucocorticoids, or if it is contraindicated, we can use the immunotherapy agents. So, after starting immunomodulating therapy and resuming the anticholinesterase medications, then only we can consider weaning the patient. So, once that myasthenic crisis, that stage starts to improve and the patient meets all the criteria for the weaning, which we will discuss in a bit, then only we will be able to wean the patient. So, here the VC, the vital capacity should be more than 15 to 20, and the MIP more negative than the minus 25 to minus 30 mark. And also the patient should have adequate cough, and we should be able to manage the secretions as well. And coming next to the other ICU management, we will have to do a septic and soft suctioning of the secretions, and aggressive respiratory therapy is required, including intermittent positive pressure breathing, sigh exercise, cough augmentation, and chest physiotherapy. So, also the bronchodilator usage we can use ipratropium bromide, as it causes less bronchial secretions, and also the inspired gas we will have to humidify to thin out the secretions as well. And early placement of feeding tubes and the maintenance of caloric intake at around 25 to 35 calories per kg or a low carbohydrate feed is required to reduce the hypercarbia. And also we will have to maintain the electrolytes. We should avoid overcorrecting the hypomagnesemia and also correct the other potassium and phosphate balance as well. And treatment of anemia is also required. We should transfuse when the hematocrit values are under 30%. And also we should give the DVT prophylaxis with any compression stockings or any heparin injections. And also the hemodynamic stability, and we have to monitor continuously. The cardiac monitoring has to be done, and also the aggressive treatment of fever and infection with effective antibiotic therapy and optimal pain management should also be done. And also we have a ADL scale, which is a simple summation score of myasthenic symptoms reflecting the disease severity, and an ADL score of greater than 18 accurately predicted the need for ICU management with a sensitivity of around 75 and a specificity of 78%. And the further respiratory management, the NIV may be used in patients with myasthenic crisis who are expected to improve quickly or who have adequate cough and can tolerate the mask. So, in those patients only we will have to give a trial of NIV before going for intubation. And also these patients should be able to have adequate cough, and also we start this as an early therapy prior to the development of the severe hypercapnia or acidosis, and to prevent atelectasis, open the upper airway, and to relieve the early mild respiratory muscle weakness only. And also we should avoid a prolonged use of NIV, as if the patient fails to respond to NIV, then we will have to go for invasive mechanical ventilation. And coming to the intubation drugs as well, the paralytic agents which we use should also be carefully selected, because the non-depolarizing neuromuscular blocking agent, which is a rocuronium, is more preferred to succinylcholine. This is mainly because we have the relative paucity or the decrease in the acetylcholine receptors in myasthenia gravis. So, there is a relative resistance to succinylcholine, which necessitates basically higher doses of succinylcholine, and the sensitivity, increased sensitivity of the relative increased sensitivity of the non-depolarizing neuromuscular blockers such as a rocuronium agent, it will require lower doses as it is more sensitive. And coming to the ventilatory settings, mainly the optimal mode is basically unknown, and we can use the volume control ventilation at tidal volume of 6 to 10 we can use, and a low PEEP should be kept around 5 to 50, and FiO2 can be adjusted to achieve saturation of greater than 92% or a partial pressure of oxygen greater than 70 millimeters of mercury. And the patients with chronic hypercarbia and normal pH, in such as the patients with COPD, with the chronic hypercarbia, the patients we have to keep PCO2 more than 45 millimeters of mercury or around the baseline, so as to avoid alkalosis and bicarbonate wasting. And weaning should be attempted only after the initiation of IVIG or plasmapheresis, unless such treatments are contraindicated. And the simple criteria we can use for weaning is satisfactory oxygenation, then the PO2 by FiO2 of being greater than or equal to 200, the positive end expiratory pressure PEEP of being less than or equal to 8 centimeters of water, and alert level of consciousness, hemodynamic stability, and ability to cough effectively. So, once a patient meets all these criteria, then only the patient is fit for weaning. And the clinical assessment of bulbar muscles such as the neck flexors is also important to assess for any residual bulbar muscle weakness. Tracheostomy is indicated if the patient is intubated for more than 2 weeks. Rapid therapies, we have the IVIG and plasmapheresis. The standard dose is 2 IVIG is 2 gram per kg. It is administered over a period of 2 to 5 days, which is 400 mg per kg. And plasmapheresis, it removes the acetylcholine receptor antibodies from circulation, and we can actually do 5 exchanges in total over 7 to 14 days, and each exchange we can remove around we can exchange around 3 to 5 liters of plasma. And the improvement is usually evident by the 4th or 5th day of IVIG treatment, or by the 2nd or 3rd plasmapheresis session, and the effect basically lasts for weeks. And by that time we will get the chronic immunomodulating therapy to work and prevent the further crisis. So, coming to the chronic immunomodulating therapy, which is the steroids, we'll have to concurrently initiate it to sustain the effects of the rapid therapy, and the onset of steroid begins within 2 to 3 weeks, and by that time we'll be having the effects of that IVIG and the plasmapheresis, and it peaks by around 5 to 5.5 months. And the initiation of high dose glucocorticoids is associated with initially a transient worsening will be there initially, transient worsening of the weakness, which is seen within 5 to 10 days of initiation, and it lasts for only 5 or 6 days, and then it comes back to normal. So, this effect is countered with the initiation of the plasma exchange or IVIG, and the quick onset of the action of these rapid therapies helps to prevent the transient worsening. And also we can give oral or nasogastric glucocorticoids at moderate to high doses. Prednisolone 60 to 80 mg daily can be given, and if the patient has significant infection only, then we can delay the corticosteroid treatment unless the infection is controlled. And steroid sparing immunotherapy, we have the other agents such as the azathioprine, mycophenolate, mofetil, tacrolimus, rituximab, methotrexate, F-gartigimod alpha, and ravulizumab and cyclosporins. These are actually used to lower the dose of glucocorticoids, or when they are contraindicated, then only we should use the immunotherapy, and these agents also have long term benefit and is not useful during the myasthenic crisis as such. Then other newer therapies is basically the complement inhibitor, which is the eculizumab, and the neonatal Fc receptor antagonist, which is the F-gartigimod, and these have a relatively rapid onset of action and have a role in the treatment of myasthenic crisis, especially those who fail to respond to IVIG or plasmapheresis. Eculizumab has been used in 13 patients with myasthenic crisis so far, and who did not respond mainly to the IVIG. These patients actually had a positive response to this eculizumab. Most of them are actually AChR antibody positive as well, and the F-gartigimod is also has the action of homeostasis of the IgG. The IgG will be lowered. The IgG levels will be lowered by this compound F-gartigimod, and as it rescues the IgG from lysosomal degradation and recycling. So, by rescuing the IgGs from lysosomal degradation and recycling, it basically lowers the levels of IgG, including the AChR antibodies, and it further improves the myasthenic crisis. Then in pregnancy, exacerbations are more likely to occur basically in the first trimester or during the postpartum period, and also the cessation of immunosuppressive medications during this period, as well as the physiologic stress of labor and delivery, could all serve as a trigger for myasthenic crisis, and several treatments used for the long term disease control are contraindicated during pregnancy. But both IVIG and plasmapheresis can be used, and when plasmapheresis is done, we should be careful while doing it, and large fluid shift and intravascular volume depletion should be avoided. And hypercoagulable status in pregnancy can be exacerbated by the IVIG or the plasmapheresis, so we monitor for venous thrombosis. And also the patient can be exposed to medications which can lead to myasthenic crisis, as we discussed earlier, the precipitants, which is the IV magnesium for the treatment of preeclampsia, or the antibiotics like fluoroquinolones to treat UTI. And the thymectomy is another important option for selected patients. It's not useful in the myasthenic crisis period, but once the patient stabilizes, we can plan for a thymectomy. And also it is done due to the potential cardiopulmonary complications and the risk of metastasis with the thymoma, and also it should be done after a course of the IVIG or plasmapheresis, or once the myasthenic crisis phase stabilizes. So, coming to the complications, it can cause infections such as pneumonia, bronchitis, UTI, bacteremia, sepsis, Clostridium difficile, colitis infections, as well as it can cause vascular complications such as DVT, heart failure, acute MI, cardiac arrhythmias, cardiac arrest, stress-induced cardiomyopathy, all can occur. And also the prognosis, basically the most common cause of death is not the myasthenic crisis itself, is due to the multi-organ failure due to the sepsis, and also it can be due to respiratory failure as well, despite maximal care. And also the factors associated with poor prognosis include age greater than 50 years, severe MG myasthenia gravis status or severe disease severity of the myasthenia, gravis, and also the lower baseline vital capacity or the medical comorbidities the patient has, or the ARDS, the duration of the ventilator support if it is prolonged, or the crisis triggered by the systemic infection, severe anemia, septic shock, cardiac arrest. All of these indicate poor prognosis of myasthenic crisis. Thank you, and so I hope you understood what is the basic definition of myasthenic crisis, when we should suspect myasthenic crisis, and what is the test we can basically do to early assess for impending myasthenic crisis, or to assess for the need for intubation, the criteria and all, when we should intubate the patient electively, and also the further ventilatory settings and the weaning criteria, and also what are complications we'll have to take care of during the course in the hospital, and also the how to differentiate between the myasthenic crisis and the cholinergic crisis, and also if the patient presents initially with a unknown background of myasthenia gravis, what all differential diagnosis we should keep and rule out to come to a correct diagnosis. Thank you.